Hi, my name's Alec Young. I'm a third year medical student at OSU, and I will be presenting a case report on greater trochanter fracture and fixation in a teenage athlete. So, isolated greater trochanter fractures aren't really a common thing that we see in practice. Um, Therefore, there's not a lot of literature on the incidence and even the management of this. So, with these fracture patterns in younger patients is normally due to an avulsion injury with a strong hip abduction, whereas older patients, we see it. It can be due to traumatic injury, but it can even be due to a pathologic process. And sometimes these hip fractures can be managed with non-operative management. Um, but once we start to widen that gap greater than 1 centimeter, that's where we start to look at fixating things so we can heal properly. with with the pediatric population, especially, but really just anytime we have a fracture, especially around that femoral neck and greater trochanter, we worry about avascular necrosis due to disruption of the medial circumflex femoral artery. And therefore, that kind of pushes our hand more likely to fixate rather than to non-op these to make sure that they're healing properly. So, kind of more so the concern when we get with the pediatric population is as they're still growing, they're relying on that blood supply. And so we want to make sure that we're doing everything possible so that we don't have avascular necrosis and affecting a younger patient's trajectory in life. So the case that we have is a 14-year-old male presented to the emergency department following a dog pile football play. He was neurovascularly intact and had pain with motion of his right hip. And so we got plain films and an MRI to confirm or to demonstrate a isolated greater trochanter fracture with no extension into the femoral neck. The orthopedic trauma team was then consulted, and patient was scheduled for an open reduction and internal fixation of the greater trochanter, and we can see those images below. Intraoperatively, the fracture was reduced under direct visualization and then held with some K-wires to not slip out, and then confirmed that with fluoroscopy. A semitubular Smith & Nephew plate was contoured to the bone and then fixated with screws. Fixation was then confirmed to be stable with mobility of the hip. And so then we see this intraoperative image demonstrating our fixation here. The patient was then discharged with restrictions for touchdown weight bearing with crutches. He presented at his first 2-week post-op visit with a well-healed incision and remaining intact motor and sensory function. Continued to be weight-bearing as tolerated at this point, and then presented at his 8-week post-op visit with continued improvement. And then following up at his 3 months post-op visit, doing well with activity, mobilizing well. And so at that point, he was given no activity restrictions and planned to follow up 6 to 8 months from then for a potential hardware removal. So just conclusions, reminder that these are rare injuries, and so just being aware of this possibility. So especially in younger athletes, we want prompt and definitive treatment, such as open reduction internal fixation. That way we don't lead to avascular necrosis. And then in this patient's instance, returning back to play. The surgery itself, though, isn't without risk, so we do need to be aware of that. That if you aren't doing this properly, you could actually, with your fixation, end up disrupting the blood supply itself. So need to be aware of your complications and making sure that you're locking down properly. And just the lack of literature on this and the rarity of this injury just underscores the importance of recognizing this pathology and therefore calling for more research of this injury. Thank you.